Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple-board certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving into special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hi, good morning. How are you? It's Dr. Lederman with the Radiosurgery Hour. Hope you all had a good week. I'm here to tell you more news, new news, talk to you. If you have questions, you're welcome to call us. We're live at the WOR studios. If you have questions, our number is 1-800-321-0710. Again, that's 1-800-321-0710. So there was lots of news, lots of patients, and lots of things to discuss, and we hope that you learned from all these things, gets you better health care for yourself and your loved ones. And we're going to start right away. So our first patient, this interesting man, came to us from Staten Island, where he was just in the last 2 weeks diagnosed with an acoustic neuroma, which is a particular kind of brain tumor. Acoustic neuromas are benign tumors. They're tumors that affect the nerve that go from the brain to the ear. And obviously the ear does two things. One is to provide hearing, and the second is balance. So tumors affect this nerve. The nerve is like an electrical wire that connects the ear, the functions of the ear, to the functions of the brain. And on the brain stem, there's 12 cranial nerves on each side, so 24 altogether. And the right ear and the left ear is connected by the 8th nerve, the right nerve, and the left nerve. So there's two acoustic neuromas possible, and some people, in fact, have a disease called neurofibromatosis 2, a very rare disease, but can affect both hearing nerves. And we actually see a lot of acoustic neuroma patients. We see a lot of patients, and a few will have NF2, neurofibromatosis 2, which affects both ears and also multiple brain tumors. This man did not have NF2. He had what's called sporadic acoustic neuroma. He was fine until a couple of weeks ago when he started developing muffled sounds on the left side of his head. He had tinnitus, which is ringing in the ears, and he had a pressure sensation in the ear. So he did the right thing. He went to his doctor. He got an MRI. The MRI showed a small tumor consistent with an acoustic neuroma. And luckily he had a friend who I treated years ago and is doing well, which is how most all of our patients are doing with acoustic neuromas, because our treatment is a non-invasive treatment compared to surgery, which actually opens up the head and someone's hands are in one's head. Our treatment is totally non-invasive. We've been at this for decades, and we have the largest experience with fractionated radiosurgery, which is non-invasive treatment. Unlike Gamma Knife, there's no pins in the head, there's no screws in the head, and also we have the advantage of dividing the dose into several fractions. What's the advantage? Well, doctors have known since the 1920s, almost 90 years, that if you divide the dose up into a few fractions, you help protect the normal, healthy tissues. And in this case, the normal, healthy tissue is that healthy nerve that's underneath that tumor. So if you can protect the nerve, you can protect the hearing and have a better chance of protecting the other cranial nerves in the neighborhood. The most important two are the seventh nerve, which is carrying movement function for the face, and that's why after surgery that seventh nerve is often cut and the patient has a paralyzed face. The other nerve that's often affected with surgery is the fifth nerve, which is responsible for sensation of the face. So with us, the vast majority, about 97% of our patients, are in remission, and this is for the rest of the life of the patient. We've been following patients for decades. We have a unique program with the lowest biologic dose. Why is the lowest dose important? Well, the lowest dose means less chance for complications. Obviously, people, I believe, who have a tumor, they want to be normal, they want to live normally, have a normal lifespan, and avoid radical surgery. And we certainly allow this for the vast majority, about 97% of our patients. And also most of our patients maintain their hearing. Not always, but quite a high proportion maintain it, and a few even, about 20%, have improved hearing. Our group was the first group to report improved hearing after acoustic neuroma treatment. Most places who do this work, and there's not so many who are experienced at it, give a much higher dose. Well, higher dose radiation can harm the nerve, and we want to obviously protect the nerve. So that's why we do what we do, and I explained this all to this gentleman who's very thoughtful and smart, and he's doing his work. He's investigating the options, and we'll bring in his wife. We'll talk about everything. I insisted actually on that because it's important for both the husband and the wife to know exactly what's going on, and then when they're comfortable, we can offer treatment if they want. There's usually only 5 treatments. Each treatment's about 15-20 minutes. People come in, get a treatment. Excuse me, the beam is directed right at the tumor. Patients get off the table and resume their normal life. This man could even come at the end of work, get treatment, and I believe be fully functional without any significant side effects, So I wish him well. If you have other questions about benign tumors in the head, and the most common ones are like this: acoustic neuromas, meningiomas, pituitary tumors. We have a vast experience. We were the first in New York with brain radiosurgery and the first in New York with fractionated brain radiosurgery. So it's worth the experience. It's worth a team that is devoted to this work. We also obviously treat cancers in the brain, like metastasis and glioblastomas and astrocytomas. So if you have a question, call us. We also have a booklet to send to people interested. If you call us during the work week, Monday through Friday, 9 to 5, we'll put a booklet and a DVD in the mail to you about our work. And another interesting woman who came to us, unfortunately, she did not come first to us. She came after calamity struck twice. About a 60-year-old woman. She had a mass in the thigh, the left thigh, that was more than 5 inches in size. This was a couple of years ago. She got an MRI. She had a biopsy. The biopsy showed sarcoma. She then had surgery on that sarcoma and was treated at a hospital in Long Island. When they cut out a cancer, and when you cut out a cancer in general, you want good margins, especially for an aggressive cancer like a liposarcoma. Well, their margins were 1/2 millimeter, so that's about 1/50th of an inch. Really, really small margins for a big tumor. The tumor was 10.5 by 9 by 6 centimeters. She then had standard radiation there and remained weak. She had pain. Her doctors then did a scan when she had more pain, And in fact, a 6-centimeter mass was seen in the left hip, just above the site of where this tumor was removed. Well, they waited another couple of months to do a biopsy. I don't know why, and the biopsy was negative. And then they told her to wait another 4 months, which is now. So the pain is getting worse. She's walking with a cane. She's got a mass in her pelvis. It seems strange that it's almost been a year since she had a mass detected and still no diagnosis. She had a new MRI which showed a second lesion in the pelvis. So obviously this is a tumor that is growing, and most likely it is her liposarcoma, her sarcoma. Sarcomas are cancers of the connective tissues, like the muscles and bones and the parts of the body that hold us together, hold our body together, actually. So she came to us. We arranged to get a biopsy immediately, if she wishes. I think it's important. By the way, she was taking a lot of herbs, and it wasn't controlling her tumor as you would expect. There's no data, actually, to show that herbs and alternative medicines help on liposarcoma. So we believe, and I believe, that she most probably has a recurrent liposarcoma in the hip area. She had standard radiation, which doesn't work very well for sarcomas. If you look in books, a lot of books will say that sarcomas are radio-resistant. Well, they're not really radio-resistant. In fact, our highest control rate are in so-called radio-resistant tumors like kidney cancers, melanomas, sarcomas. And the reason is there's something called a dose-response curve. So if you give 35 little treatments, it doesn't work very well. But if you give radiosurgery, which is high-dose treatment that's focused on the cancer, actually the success rate is about 90% in stopping or shrinking that cancer or making it go away for the rest of the life of the patient. So we arranged to get her worked up. We arranged to get a biopsy. Most probably she will be, if she chooses to come with us, successfully treated where we attack this cancer. We'll report back to you. If you have questions about sarcomas, just give us a call. Our office is 212-CHOICES, 212-CHOICES. And another interesting man, actually this man came from Florida this week. He has a rectal cancer with spread of the rectal cancer to the liver. He's 83 years old, and his daughter kept pushing him to get colonoscopy, which everyone should have colonoscopy. You know the data, if you find a rectal tumor early, the success rate's much higher than if you find it late. Well, actually, he finally agreed to get a rectal evaluation by colonoscopy, and at that time, which was in October 2013, recently, the doctors couldn't even pass the scope beyond the rectum. There was a big mass there, and unfortunately, when the rectum cancer was diagnosed, it had already spread to the liver, so it was stage 4. He's been on chemotherapy, and the chemos worked pretty well, but one area in the liver keeps growing. So why would that be? Why would chemo work in one area but not another area of a patient? Well, there's something called tumor heterogeneity, and I often tell people it's like if you have children, or if you're a child, why aren't you and your brother and your sister all alike? You have the same parents, and the same house, and the same food, and probably the same school, but each one's different. Well, just the same in cancer. Sometimes the cancer cells evolve with a clone. So one clone changes. One clone might be sensitive to one treatment and not sensitive to another treatment. Now, I should tell you that generally with radiosurgery, that's not true. Usually all of them are sensitive, and the reason is that radiosurgery works in billions and billions of different ways, so the cancer cells are much less likely to become resistant than with chemotherapy. So this man had one nodule in the liver. We had all his scans reviewed. He's doing great, although he had lost 20 pounds. He was down from 178 to 159. Fully functional, living in Florida, flying around. We treated him He's had 2 treatments already. He's going to have 3 treatments